My name is Kristen, and I will be discussing the therapeutic updates, best practices, and barriers to care in the treatment of epilepsy and seizure disorders. The objectives of my talk are to describe the pathophysiology associated with the diagnosis of epilepsy and apply existing diagnostic recommendations and criteria to the practice in the management of epilepsy. We'll also discuss some of the treatment modalities that are available to manage epilepsy. We'll apply these treatment regimens to patient cases using evidence-based medicine. We'll also evaluate treatment plans for patients on specific drug therapy in order to make sure we're optimizing the safety and efficacy of those medications and suggest any modifications for improvement. We'll also be describing the challenges and barriers to care associated with treating patients with epilepsy. The definition of epilepsy has traditionally been defined as the occurrence of at least 2 unprovoked seizures separated by 24 hours. The International League Against Epilepsy has a consensus statement that's out there where they define epilepsy as a chronic condition of the brain characterized by an enduring propensity to generate epileptic seizures and by the neurobiological, cognitive, psychological, and social consequences of this condition. This basically acknowledges there's an abnormality even when seizures are not present. It's common to have seizures and to not have epilepsy. So the incidence of seizures could be greater in males versus females. The age-adjusted incidence of epilepsy ranges from 24 to 53 per 100,000 patient years. 30% of these cases are under the age of 18, and there's a bimodal distribution. So this means that there's a peak occurring in newborn and young children, and the second peak can occur in later years of life when a patient is greater than 65 years of age. The overall prognosis for seizure is pretty good. Over 70% of the patients will enter remission. This long-term remission is, majority of that will be diagnosed within the first 5 years. Your patient may have this 70% chance of entering remission. An early response to anti-epileptics is a good predictor of a good outcome. Epilepsy can also carry an increased risk of premature death. The classification of seizures. So the International League Against Epilepsy has a commission where they put out a few consensus statements on how to classify all the different types of epileptic seizures. The classification of all the different types of epilepsies is beyond the scope of this lecture. However, this is a good reference here to note in case you're looking for further information on how to classify all the different types of epilepsies. In order to classify the different types of seizures, the International League Against Epilepsy has a statement in this publication where they review the current classification system of seizures. They have generalized seizures, which are broken down into tonic-clonic, absence, myoclonic, clonic, tonic, and atonic seizures. They also break down focal seizures and unknown seizures. Traditionally, focal seizures used to be distinguished between complex partial and simple partial seizures. However, that distinction has been eliminated, and the ILAE just refers to focal seizures moving forward. The ILAE Commission has seizure classifications for generalized seizures, for which we'll look in closer detail at. So generalized seizures are a diffuse disturbance of the cortical function. Seizures begin in both hemispheres, and looking at the different types of generalized seizures, again, we have tonic-clonic, absence, myoclonic, clonic, tonic, and atonic seizures. The description and the autonomic changes in the duration for each seizure type is listed here. Tonic-clonic seizures usually begin with symmetric movement and tonic rigidity followed by a clonic phase. There is a loss of consciousness which can last up to 1 minute, and the autonomic changes are listed there for your reference. Absence seizures also are associated with loss of consciousness. There can be subtle clonic movements that are bilateral and symmetric. They could be limited to blinking eyes or facial movements, or rocking changes related to postural tone. These typically are shorter in duration. Myoclonic seizures are typically sudden, involuntary, brief, shock-like, muscle-like contractions, which are unilateral or bilateral, and they're isolated.